I am Dr. Kiran, orthopedic and spine surgeon working at present in Abu Dhabi, and I would like to show you how patients neglecting their spinal problems land in several problems. Sometimes life is devastated because of the decision to postpone. It's not that they purposefully neglect. Sometimes they're afraid and sometimes they do neglect.
The reason for taking a low back ache episode lightly is because most of us have it at one point of our life or the other. Even neurologists and orthospine surgeons encounter it very commonly. So there is a tendency of taking it lightly, while the danger lurks if we are not careful.
I have a few instances when I encountered patients who did this and really suffered in spite of my repeated instructions and cautionings to them. So in this scenario, the most dangerous thing is acute disc prolapse or a chronic disc prolapse. What happens is, in 2-3 lines I can tell, my neck is the spinal cord, my right arm is the nerve root going to the limbs, left arm is like the nerve going to the left limbs, lower limbs. Suppose if the disc comes from the front and presses my throat, my voice has changed. You neglect even further. I'm not able to speak. You press more, I will die. So when a doctor comes and says, please go for surgery, they should listen. First thing. Second thing, they should not depend on the advice given by their colleagues. You do spine surgery, you will get paralyzed. No. Acute or chronic, the sequences may vary a little, but the end result is damage to the nerve. See the picture, you will understand that it is not simply the nerves that go out. The nerves have life or the normal conduction velocity. They work as nerves as long as their nourishment is taken care of. Their myelin sheath is intact. Okay, so we have a lot of vessels, arterioles, venules. They come and supply the blood and also take away the blood. Now what happens when there is a very severe disc, for example in the center like this, when the disc has gone like this, especially in the cauda equina, which is the main reason why I want to present this. Cauda equina are nerves like this. The spinal cord is a continuation of the brain, and then it runs till L1 or L2. See, anatomical variations will be there. Sometimes it ends at higher level or at a lower level. That confuses the clinician or the neurologist also. So that is why a team approach always is required when we deal with spine surgeries, because the clinical picture, sensations, motor deficits can vary from person to person depending on where the cauda equina start, where his conus ends. Conus medullaris is the bulbous ending which we see at the lower portion of the L1, which normally is the location for the spinal cord to end. But the spinal cord ends, and from there, does it end? No, along with the 3 layers of the pia mater, arachnoid and the dura mater, you have the spinal nerves continuing distally into the limbs, into various plexus, and these parallel row of nerves, they look like the tail of a horse. It's called as Cauda equina, tail of a horse. Now these tail of the horse, we should not forget. Just look at this. What you have here, you have the spinal cord ending here, and then as we go down, the Cauda equina starts, and these Cauda equina, how do they end? They form nerve circuits which stimulate the sphincter control. Now these nerves, as they are falling down, you may have different kind of scenarios appearing before you.
Scenario 1. It's just a mechanical backache. We all have it when we sit down, when we bend and do some yoga on a wrong posture, or sit for a long time, twist our spines, or the laborers picking up big weights, drivers who continuously drive, they all have mechanical backaches which disappear within 3 to 5 weeks with precautions. Loss of weight, spinal strengthening exercises help a lot. Even posture is vital. Now, scenario 2. Patient speaks openly about their added bladder weakness. They are not able to control their urine. Bowel constipation, sometimes they are not able to hold their bladder evacuation properly. Sexual dysfunction like erectile dysfunctions, etc. When they speak about this, it's easier for the doctor to plan further. Scenario 3. They are very shy. They are not relating this problem to a disc or a spinal compression. Here, the surgeon or the clinician, it's very difficult for them to assess and plan the right treatment. Why? Any wrong overlook means a disaster for the patient. The scenario 4, in this situation, the patient knows that there is an impending paralysis. He knows with each visit, he or her comes to the doctor saying that, "Doctor, I'm not able to control my sphincters, I'm not able to walk," and he's barely able to walk. Doctor examines, does all the tests, counsels, still the patient prefers to ignore the weakness in the sphincters and the limbs. This is a potential situation for a medico-legal issue later, and the doctor must record the serial deterioration in every visit that the patient makes, because tomorrow we never know who will be in problem. Both may be in problem, patient and the doctor. Scenario 5 is about a patient who was counseled well and he gave consent on his own, voluntary consent. During the surgical procedure, the decompression was not complete, and the Cauda Equina nerves continue to be compressed. So, leading to a scenario where there is a Cauda Equina Syndrome which lurks and can occur at any uncertain period of time. A definite medico-legal issue will ensue. Now, coming to scenario 6, the surgery was done with a complete decompression, but the patient still has pain. Why? Was the compression acute or chronic? So it depends on the nerve damage that is pre-existent to a spinal surgery, and this must be counseled to the patient, and the patient must own it up. Also, it must be mentioned in the informed consent, surgical consent, which is a legal document. This is a precaution I would always advise to all the spine surgeons around the world.
A patient may come and say, "Doctor, I'm not able to walk properly. I feel heavy." It's a bad sign. "Doctor, I have urine problem." He cannot say what is the problem. So it's us to ask. It's our doctor's role. I ask, "What is the problem?" And I tell them a scenario. What is happening? He just hesitates sometimes. Going to the washroom, do you find 2-3 drops in your innerwear? He says, "Yes, doctor, it's very embarrassing sometimes." Early signs of slow progressive Cauda Equina. If the doctor misses, God save the patient, because patient is innocent sometimes, mostly. And third thing, "Doctor, I have motion, my daily, I'm not able to evacuate or empty my bowel." One early symptom. Or I cannot control my sphincter. Again, another important symptom of Cauda Equina Syndrome. Some people will say, "Sir, I am not able to perform my sexual activities." Male. He says usually, "Sir, I have erectile dysfunction." This is a very important aspect, and I would like to really emphasize, our neurological charts, internationally accepted neurological charts, keep a mention. But I think more emphasis must be given and training must be given to all orthopedic and neurosurgeons to please give emphasis on this aspect, because that is a very important aspect which affects their social and family life. So, erectile dysfunction in the male, Now, what happens to the female? She will not have the climax or the orgasm. They are not, again I'm telling you, it is not shameful. It's a human body. If we take care of our eyelids, our lips, lipsticks, if we take care of good shirts, good ties and everything, please, let's give importance to the basic human physiological needs of a human being. And when a patient comes, give importance to that advice. If they don't listen, it's not the doctor's fault. And today, the medical legal scenario has changed so much that no more doctor is a god. Please, doctors, record, not only document written, also have video records with their consent, written consent. And if you are speaking a foreign language, make it a point, you have a translator. Now, coming to cauda equina. If cauda equina compression suddenly occurs, there is a sequence of arterial venous blockade. There is a sequence of compression. How much compression will produce cauda equina paralysis? Cauda equina is a peripheral nerve, means it might regain, but the damage will be very severe, with loss of tone, no reflexes when we test with a knee hammer, saddle anesthesia. You can ask the patient, when you sit on a table or a chair, wherever you sit, do you feel the area where you are sitting? If he says, sir, numb, it's numb, sir, it is numb. Very important, very early sign of Cauda Equina Syndrome. He's going into paralysis. So with this, I'm going to show you the various reasons why the lumbar spine can be affected. We can have serious disc prolapses. See, this is in the lumbar region. Now I will show you a lumbar region with a thoracic level disc. Unusual, because this is the neck is the mobile part and then the spine is the mobile part. These are all fixed regions. You get rarely a thoracic disc, but if a thoracic disc appears, a herniation appears out, compressing the spinal canal, there will be catastrophic upper motor neuron lesion paralysis. Definitely without recovery. If it's higher up, even something else can also happen. Now the second scenario is, I have found in some regions, like after I came to Middle East, I am seeing more of dilated veins inside the spinal canal extradurally, which is surprising me, like this. So they add to the arterial problems, venous problems inside the spinal cord, and any little pressure may cause severe paralysis or severe nerve damage. So with this I come to an ending of the lumbar spine and its various problems that may come with it. And take home message is, our spine is like a chassis of a cycle, a two-wheeler or a four-wheeler. It doesn't matter how much you add up to the exterior, the inside must be strong. See you again. Bye-bye.